I hope all the presenters are here. So we will be starting this session, Cornea Free Paper, and I'm inviting Dr. Raja Rajan. Are you here? Dr. Ashok Sharma, Dr. Leonel Raj, Dr. Shakeen Singh. Okay, so you can come and present your paper, Inlay Keratoplasty for Positive Vitreous Pressure.
Good afternoon. The technique is graft under host inlay PKP for positive pressure treatment in PKP managing beyond. This is a new technique. A purpose to describe a novice graft under host inlay PKP technique to prevent very serious complications related to positive vitreous pressure during PKP and achieving always successful grafting with the better visual outcome. PKP is the procedure of choice. In recent choices, it's a lamellar over full thickness procedure because of its less rejection rate and is considered to be safe as integrity of the globe is always preserved. However, PKP still stands as the most commonly performed corneal transplant technique by majority of the surgeons. Hence, prevention of the serious complication should be utmost interest of every corneal surgeon. So this is a total of 140 patients, and out of 140, 134 was with the routine, and the 6 patient was done with the graft under host technique. In those cases with the threat of a high BVP, we resorted to a new step of tissue exchange, that is the host cornea button is not removed completely as a whole, but is kept attached at 2 locations, preferably 180-degree apart, and the donor tissue is slid underneath the host cornea before complete swearing and viscoelastic injected into AC to prevent endothelial damage. 3 to 4 stage sutures are applied to fix the donor tissue to host rim and is followed by segmental host cornea cutting, and only after achieving a stabilization of the graft tissue, the host button is removed. Once the graft is secured, regular suturing with the continuous or interpreter suture is done. This is a diagrammatic picture of all those steps, 6 steps what we do. And these are small videos. For the interest of time, I will run these fast. This is when once you feel the threat, you put the graft underneath and then you proceed with your procedure. That's going to save the sudden surge of the vitreous and making the things happen worse, like a expulsive hemorrhage. So once you have achieved this, then you can go into for completion of your sutures. A successful cornea transplant was achieved in all patients. In all 6 complicated cases, despite encountering the unsuspected PVP, there was no primary graft failure and cornea graft remained clear. Inlay technique graft under host was no different from graft operation by the other procedure when we followed these patients, and the success rate was almost 95%. Conclusion: what was known? PKP is an open sky procedure, so there is a high risk of complications that can result in suboptimal post-operative complications. PVP during PKP is still remain challenging and unpredictable despite adequate peri-operative preventive measures. It has been reported that during PKP the incidence rate of PVP is 40 to 50%. What this paper adds: this novice technique adds stepwise and segmental wise cutting of a host button followed by suturing of the donor tissue, which is placed as an inlay. Therefore, it must be incorporated in challenging cases to prevent sight-threatening complications like PVP related to vitreous prolapse or expulsive hemorrhage. Otherwise, face the expulsion of the intraocular content where you might have to abandon the procedure. Recent technique of overlay grafting can be performed, but that leads to extensive endothelial cell damage by compromising visual rehabilitation. Inlay PKP is a step forward towards achieving safe surgery, better graft survivability, and better visual recovery. Thank you.
Nice presentation. So, like, my question is, like, don't you think that you are putting a graft under that it's causing overcrowding and more endothelial damage in that?
Sir, this is the concept in this procedure. Like, you put a graft under the host with the bed of the viscoelastic over the iris. So you have still a small space which would not be possible to do when you put the graft like an overlay. So here we are putting a graft underneath, creating some space. The endothelium is being protected by the viscoelastic at that time moment. And once you are stabilized, then you can proceed on the further. Definitely you have taken all perioperative measures before you start the surgery. But in few patients you come across this kind of pictures. And in those cases I find this is the very good procedure to save and we can complete the procedure.
So how many cases you have done like this and before?
In this study we did in over a year of 1 year, this is a
Okay.
140 patient and 6 patient was like this. So there are a few more patients which has been done previously and after that.
So that's what, like, do you compare your previous patients and like after patients, what are the endothelial, do you think the same amount of?
So yeah, that's what we have mentioned. It's almost the same.
Almost the same.
Almost the same.
Don't you think there will be overreading at the host cornea where it is attached? Overreading
Definitely
of the
there's a
graft.
compromise space in between. Once you are not tackle that
Because
situation,
you are,
either you have to abandon the procedure because there's a high posterior vitreous pressure, or it's going to go into expulsive hemorrhage. It's a dreadful complication. So right there when you judge that's going to be a posterior pressure, so don't complete the dissection completely, create a space, put the graft over the viscoelastics, and then you can proceed. Stepwise you can encounter. Because of scarcity of the time, I could not explain detail the video, but once you would go through the video, you can see, okay, when there's a less space, we can proceed with this procedure.
Like, what are the things we do to prevent positive precipitation?
So usually in the perioperative period, we make the IOPs well controlled. You give glycerol, mannitol. We always give a mannitol preoperative to the patients. Always. Any patient would go to OT.
How
So half an
before
hour.
you give?
Half an hour, sir.
Half an hour.
Half an hour.
Okay. So half an hour you give before and then you start doing the procedure. So it
Yeah.
will become like by the time effect. So
you
usually
see-
the 15 minutes the mannitol effect starts and it start waning after that.
So,
So 1 hour the state.
So before the OT, you give half an hour, you give a mannitol. It's going to take 5-10 minutes. And by the time you're going to start, it's going to be there.
Okay. This like how
And
many
of course,
cases you have
this
any?
is added with the Diamox too.
Yeah. No, have you had any cases of like suprachoroidal hemorrhage in your cases?
Luckily,
How-
so far not.
So
I
what make you
I
feel-
opted to this procedure because one fine time I had to abandon the procedure. So we are using steel suture, and that the cornea was really much scarred. I could make it well in time. So there was a choroidal effusion. I could judge it there afterwards with a B scan, but I could steel suture the immediately that time.
Okay. Another question, like when you are putting the graft under and then you are suturing, so what is the effect on corneal cylinder you get after that? Pre and like before you
So
case and
basically, what we save that time to put the graft in place. Definitely, you have an area which is less as compared to normal PKP. You have a visco with you to help it. Once you made all those 4 sutures, stay sutures appropriately, securing them in place, then you have a suture in your hand to proceed further, interrupted or continuous. I usually prefer continuous sutures, and there's no difference of astigmatic error coming afterwards.
so this is just a stay suture. You are not continuing with this. You are removing this suture after.
The 4 stay sutures that is going to make the graft stay there. Then you have your own routine suturing because it's going to contain the content there.
Okay, thank you so much.
Thank you.
So next will I, Doctor. Do we have Dr. Murlidhar Ramappa? Dr. Haritha Gaur? So she will be presenting her paper on ocular cicatricial pemphigoid with systemic autoimmune diseases, a case series. Dr. Haritha. This one, sir. Yeah. No.
Good afternoon, everyone.
Up next.
This is a case series on ocular cicatricial pemphigoid with systemic autoimmune diseases. OCP is a chronic autoimmune disease marked by conjunctival scarring. The association of OCP with systemic connective tissue disorders has a synergistic effect, leading to severely compromised ocular surface, and understanding this relationship is most vital. Our aim was to report the clinical features and management outcomes of OCP with systemic autoimmune connective tissue disorders. Retrospectively, medical records of 7 patients with CTD and OCP were reviewed. All patients were subjected to conjunctival biopsy of both eyes and processed for direct immunofluorescence. They also underwent systemic investigations, including CTD profile. All of them were taken a rheumatologist consult prior to the immunomodulatory therapy. 14 eyes of 7 patients were included in this study. Mean age was 53 years with a female preponderance, and the median follow-up was 9 months. Out of the 7 patients, 1 patient had primary Sjogren's syndrome and 6 patients had rheumatoid arthritis. Out of the 7 patients, 4 of them were diagnosed to have CTD after the ophthalmic consultation. 2 of these patients were positive with human immunodeficiency virus infection. Case 1 presented with bilateral healed PUK. Case 2 had presented with bilateral filamentary keratitis. Case 3 had presented with significant corneal shortening. Case 4 had an asymmetric presentation with limbal stem cell deficiency in one eye. Similarly, case 5 also had an asymmetric presentation with central thinning and scarring in one eye. Case 6 and 7 were positive with HIV infection. Case 6 had significant surface inflammation, and case 7 is a special case which presented with bilateral corneal thinning and recurrent corneal perforations. To summarize the clinical findings, majority of the patients had phoneal shortening. However, 50% patients also presented with corneal scar. The connective tissue disease presentation included findings of filamentary keratitis and healed PUK. And most importantly, aqueous deficiency dry eye was documented in 85% of the eyes. DIF was positive in 10 out of 14 eyes. However, bilateral positivity was noted only in 3 out of 7 patients. All the patients received immunomodulatory therapy with oral methotrexate and folic acid. 6 out of 7 patients, that is 85%. One patient who was HIV positive with high viral load and low CD4 count was not immunosuppressed. 6 of these patients, the surface was stabilized. None of them had any relapse during this period, nor adverse effects to immunotherapy. 3 line of visual improvement with a significant p-value was obtained after visual rehabilitation, with 85% cases receiving scleral contact lenses, and 28% of the eyes underwent cataract surgery. Unfortunately, the patient who had bilateral recurrent corneal presentation underwent multiple surgical interventions and ended up in phthisis bulbi in both eyes. To conclude, ocular mucous membrane pemphigoid can coexist with CTD, and a high degree of clinical suspicion is required for their diagnosis. CTD has to be ruled out, especially in those cases of OCP who present with severe dry eye or peripheral ulcerative keratitis or neurotrophic-like clinical presentation. The diagnosis of OCP has to be confirmed by direct immunofluorescence. Since the signs of both OCP and CTD can overlap, a panel of systemic investigations can help diagnose the underlying CTD. Monotherapy with immunomodulators may be sufficient in these cases to provide visual rehabilitation in conjunction with scleral contact lenses, which improve the ocular surface. Thank you.
What kind of symblophron you had encountered?
Most commonly it was medial symblepharon.
Sorry?
Medial symblepharon.
No, was it anterior, posterior, total?
It was mostly in the inferior fornix at the medial canthus.
She couldn't get to my question.
So you said there were aqueous deficient dry eyes in your patients. How did you ascertain that?
We had performed Schirmer's test to all the patients prior to any other investigations. It was done on first visit and also confirmed after the initiation of therapy.
So was not there any deficiency of wettability or any evaporative type of dry eye?
2 of the patients also had meibomian gland disease, but most of them had aqueous deficiency.
And what about mucin deficiency?
We have not worked on that, ma'am.
But we should work because it is cicatricial pemphigoid wettability problem could have been there. So I think you should have worked on all the 3 components of dry eye, isn't it?
Yes.
How many patients you have to go for surgical intervention?
Only one patient, biopsy was performed in all the 7 patients. One patient presented with recurrent corneal perforations. Every 3rd day or 4th day, she used to have a small tiny perforation. Either we would take up her TABCL or T-nonce patch graft. She underwent thrice in each of the eye. And at the end of 3 weeks, she developed panophthalmitis. and then ended up in thysis bulbi bilateral. Only one patient had such severe presentation. We could not also immunosuppress her because she was high on HIV viral load and her CD4 count was very low, that the physician was not giving clearance to start immunotherapy in her.
Dry eye is the commonest finding you have noted.
Yes, sir.
And what is the cause of dry eye? Whether it is due to rheumatoid arthritis or due to
OCP
pemphigoid?
patients usually the incidence of dry eye is not very common. Like ma'am said, it could be mucin related. Because we found out aqueous deficiency was more common, we attribute it to the presence of rheumatoid arthritis in these patients.
Yeah.
Thank you, ma'am.
Thank you, sir.
Now I call upon the next speaker, Dr. Byanjana Vaishyal. What is your membership number, ma'am? You don't remember?
It's
Every
20.
speaker must know the membership so that we can tell you. Anyway, please start your presentation. नहीं सब competitive session में है ये अपने one of the parameter.
Ratified or not?
Good afternoon, everyone. Thank you, AIOC, for giving me this opportunity. Today, I would like to discuss on innovative strategies for managing large corneal perforations in the absence of donor corneal tissue. No financial interest. As we all know, corneal perforation is an ophthalmic emergency, and smaller ones can be managed effectively using cyanoacrylate glue, whereas larger perforations await the need of tectonic keratoplasty. But sometimes it's difficult to procure eye donations, and the smile-derived lenticule are a viable, inexpensive, and available tissue which many authors have described to salvage the eyes during severe shortage of donor corneal tissue. So aim of this study was to report the outcomes of unconventional strategies and innovations for emergency management of large central and peripheral corneal perforation. This is a retrospective review of the records and management outcomes of 7 eyes of 7 patients. The patient presented with complicated corneal perforation and were managed on emergency basis using preserved allogenic scleral tissue or femtosecond smile-derived lenticule, which was cryopreserved at -80 degrees centigrade. So the results, we have included 7 patients. The mean size of corneal perforation was 3.5 mm. 5 perforations were central, whereas 2 were peripheral. The modality of surgery that we used was smile lenticular graft was used with glue or sutures in 3 eyes, along with scleral patch graft in 4 eyes. The globe integrity was preserved in all eyes at 2 months follow-up, and there was no incidence of graft displacement, aqueous leakage, additional stromal lysis, or immune rejection infection post-operatively any of the treated eyes. The BCV improved in 3 eyes and was maintained in 4 eyes. So the causes of the perforation in our cases where sterile melt was present in 4 cases, infective keratitis was 2, and traumatic perforation was there in 1 of the patient. So this is the first case where we had corneal perforation following viral keratitis. This was the photograph when the patient presented with a central perforation, and the cornea was thin around it. And so we applied a smile lenticule graft along with fibrin glue, and AMT was applied over it. And after 2 weeks, we can appreciate the globe integrity was maintained. And this is another case also of viral keratitis with a perforation in the paracentral region with vascularization and adjacent corneal thinning. Here also we have applied the glued smile lenticule. And this is a patient with infective corneal melt with hypopyon, and surrounding tissue melt also was present. Here we have applied smile lenticule, which was sutured and along with amniotic membrane over it. And this was the photograph of the patient after 1 month. And this is another patient with fungal ulcer who presented with perforation, and the anterior chamber was very shallow on the day of presentation. And here we have sutured a smile lenticule, and over that we had applied an amniotic membrane. This was the photograph after 2 weeks, and after 1 month we can see the there was uptake of the graft, and there was induction of mild vascularization, and the globe integrity was maintained. So in all the patients, the globe integrity was maintained, and various previous studies have described the use of smile lenticule in corneal perforation. Wu et al. In 2015 described 1-year follow-up of 6 patients which were managed with this, and there was no relapse of infection noticed, and 50% had improvement in BCVA. Similarly, Yang et al. Described in series of 22 patients where 54.5% were of immunological causes, and in those series the BCVA improved in 54.5% of the eyes and maintained in 40.9. So I would like to conclude saying that use of stromal lenticule from smile surgery may be considered as an alternative method for treatment of corneal ulcers before more extensive and definitive solution PK is performed. Our findings suggest that properly performed corneal smile lenticule transplantation using cryopreserved lenticules is safe and effective method. Thank you. These are my references.
The lenticule was inlay or onlay?
Lenticule as inlay, sir. Over that amniotic membrane was used.
So how you put inlay in that case?
Wherever the perforation was present, the adjacent edges were slightly debrided. The epithelium was also debrided over the rest of the edges, and where the maximum size of the corneal perforations were usually up to 5 millimeter. We can do this because the lenticule size is 6 millimeter that we've used, and in that first we put the lenticule followed by with a fibrin glue assisted attachment of the lenticule, and then amniotic membrane was put over it with the glue and sutured in the periphery.
No, what I'm asking, see, removing only epithelium will not sustain the IOP. So you were dissecting like you are making some stromal pocket.
No, we didn't make a pocket. We just
sutured it.
Sutured it there. Sutured it or put a glue over that.
Because see, fibrin glue doesn't have that much strength to hold the IOP like in that case. So if you are making a tunnel or you're suturing properly, like because interrupted suture again it will not work in this. You have to put continuous suture so that the fluid should not leak in that. If you're putting inlay like pocketing, dissecting pocket and then putting, then it's okay. But if you're putting onlay over, see epithelium is not like epithelium debride and then you put, then it is onlay only, it's not inlay. And even after that if you put the amniotic membrane, then also it's not going to serve the purpose.
Because the corneas
So
were very
like
thin. Corneas were very thin to make the pockets. This was done when there was a time of COVID and we didn't have any donor corneal tissues for managing all those perforations. So that time we rescued all these eyes with the help of smile lenticule.
So in viral keratitis, you have seen, what is the cause of melt in viral keratitis? What do you think?
The patient presented as such on the day first when the patients were presented with the perforations only. Maybe they were inadequately treated or there was recurrence of the infection that caused the further thinning of the cornea and then it was perforated.
Like viral per se is causing stromal melt or any?
No, it's because of immunological reaction that is happening and the inflammatory mediators are further causing the melt.
Yeah, that's not the infection which is causing the inflammatory mediator. So what you did for that?
For that, for viral cases, we had given topical steroids as well and antiviral therapy. But the other infective cases, we couldn't we couldn't give them topical steroid. The graft had opacified, but many studies they've suggested that the smile lenticule per se would remain clearer compared to other grafts.
Yes, the important thing is that if you put onlay over, then there should be leak actually.
Can we call it as a piggy bag or a sandwich approach?
No, when we are putting even for amniotic membrane also, when we put onlay over that, it will leak. So if you put dissect a pocket, see these are loose cornea, so easily you can dissect, and it's more than 3 millimeters. So your crescent can easily dissect, and then you can tuck it inside, and then you can put it over. So it will have a strength. So I don't know, like whether you have done Siddle test for these cases or to see whether leak is there or not.
In the day one, like the anterior chamber was well formed and IOP was well maintained.
Till the air bubble is there, it may be formed after that. Anyway, it's a good presentation.
Thank you, sir.
ठीक बेटा, thank you. अब कौन आ रहा है? क्या नाम है इनका?
Dr. Ashok Verma. I invite Dr. Ashok Verma for his presentation on predictability of corneal allograft rejection outcome, a decode using logistic regression analysis.
Second.
members on the dais and friends, I will be covering my topic, a predictability of corneal graft rejection treatment outcome, a decode using multivariate logistic regression. There is no financial interest in any of the surgical procedures or drug used in this study. Ever since the first corneal transplant was performed, there have been significant improvement in the eye banking, in surgical techniques, and new surgical procedures have also been evolved in the form of endothelial keratoplasty. However, penetrating keratoplasty remains the most common procedure being performed, and good prognosis cases have more than 90% of the success. But high-risk corneal transplants, they have like 70% of them, they fail within 10 years due to immune rejection. Predictors of the corneal graft rejection are very well studied and they are very well known. However, the prediction of the outcome of the treatment of allograft rejection has not been evaluated. I didn't find any study in the literature. My purpose was to evaluate the predictors of the outcome of treatment after corneal graft rejections. So we had a non-randomized longitudinal study which included 51 patients, and the patients who developed corneal graft rejection at various time intervals, they were included. Patients were diagnosed clinically as graft rejection. Patients, those who have herpes simplex keratitis, they were also diagnosed clinically only, seeing that the KPs were present only on the host cornea, not on the rejection side. And these are the types of the surgeries performed. Corneal thickness was noted on day 1, then 1, 2, 4, 8, and 12 weeks after treatment. And this data was subjected to the statistical analysis. We didn't find any influence of the donor demographics such as age, death, inoculation interval, death preservation interval, death surgery interval, endothelial cell count on the treatment outcome in this study. After applying the logistic regression model, we found that two variables, in like one, the indication of the surgery and the central graft thickness at presentation, they were the significant factors, and they indicated the affected the outcome of the treatment of graft rejection. The ROC revealed that the area under curve was 91%, and it suggested that the current model is good enough to differentiate between successful and unsuccessful cases. We also tried to find out whether the percentage decrease in the thickness can tell us about the treatment outcome prediction. And this is the table here showing that if you have 5% thickness at 2 weeks or 10%, then what is the risk of, what is the percentage of outcome of these cases. And these are some of the cases. The first case is basically a patient who underwent penetrating keratoplasty for keratoconus. He had endothelial decompensation following collagen cross linking done elsewhere, and she developed the graft rejection. But the corneal thickness was very low. It was 584 at presentation, which improved significantly. So low, if you have low thickness, it improves significantly. This is the other patient. She is basically herpes simplex keratitis patient, and she has undergone bilateral corneal transplant. The other eye, right eye, is doing very well. Left eye, she had this is more than 10 years follow-up now. In 10 years, she has got the second graft rejection. This is the second episode which we have recorded in this thickness study. So the presentation, at presentation, the thickness was 785, and which decreased significantly. To conclude, I would like to say that the indication of the surgery and central graft thickness are important predictors, and percentage decrease can also be a good predictor of treatment outcome. This model is further evaluated to develop the prediction model for these cases, and this is being carried out. Thank you so much for patient hearing.
Thank you, Dr. Sharma. I think I agree to it that in this era, when we have newer procedures to deal with corneal pathologies, PK has yet not lost its relevance. But from your experience, can you tell the audience which post-operative week is the most critical after you have done a successful PK on the table? Which post-operative week, first, second, third?
So for those who are my very young colleagues, I would say that the first 2-3 weeks are very important in case we are doing PKP, because the immediate complication, post-operative complications, they can be devastating. So you have to look for your sutures. All the sutures are okay, exposed, then you have to redo or do it. look for the AC depth, it should be okay, there should not be iris this thing. Then epithelial defect is most important, especially if you have a dry eye or HSK, then look for the epithelial healing. Epithelial healing is very critical in these patients. And if you are doing a regraft, maybe that second, third, or even sometimes you are doing the fourth time also, then basically I would say that the first 6 weeks are very, very important, because these patients are already sensitized and they are going to develop graft rejection immediately. So it's better to give these patients like IV methylprednisolone, and then topical steroids, and you don't cut down the topical steroids in these patients immediately. Keep them on for a longer time and do monitor the intraocular pressure, because many of these patients, the moment you give them frequent topical steroids, they develop high intraocular pressure as well.
I agree that second and third week are the most critical post-operative weeks. What point he has already mentioned, few more points I would like to mention. Be careful, look for neovascularization, limbal vessels growing, especially in the superficial layers of the cornea. 2, have an assessment of corneal thickness. If there is an increase in corneal thickness, you may land into problem in long run. Third, take care of the endothelial integrity, so that you are taking care of this thing, that there is no rejection in times to come. The standard books mention that you have to be very watchful for 2 years, even after you have done a successful PK. Any time up to 2 years, a rejection phenomena can come up. But second and third week, look for neovascularization, especially superficial vessels growing into the graft. Corneal thickness is of utmost important, paramount importance, I can tell you, and endothelial integrity.
Thank you, sir. Thank you so much.
So have you added, Dr.
I'm
Sharma,
sorry.
have you added any immunosuppressive agents in this high-risk graft?
We do use cyclosporin topically, or even tacrolimus ointment also, but not for the treatment of graft rejection. But
No, like
in
when
high-risk
when-
cases,
yeah,
post-operatively
when you
we
were
do.
doing repeat
Yeah,
keratoplasty,
definitely.
did you
definitely.
used how much percentage of cyclosporin?
Cyclosporin, madam, 0.5%.
Okay, but it is usually used for
Right.
dry eyes, not
Yes.
for preventing graft rejection.
Definitely.
For graft rejection, we have to use 2% cyclosporin. Any oral medication?
I have the problem of tolerability sometimes. So that's
Any other oral medication have you given to prevent rejection in these high-risk keratoplasties?
I have not used oral immunosuppressives for graft rejection. I rely more on topical steroids or oral steroids.
Okay, thank you so much.
Muralidhar. Dr. Lionel Raj is there? Dr. Muralidhar? Yeah. Clinicopathological correlation of corneal keloids in children.
Muralidhar Ramapur. A very good afternoon. It gives me distinct pleasure to present our work titled Clinicopathological Correlation of a Pediatric Corneal Keloid. So I do not have any relevant financial disclosure. As we all know, corneal keloids are characterized by the progressive grayish-white elevated. At times they are gelatinous, well-circumscribed corneal lesion, have a glistening white surface. Sometimes it could be chalky white or a glistening white surface. The keloids have been traditionally known to cause by the aberrant corneal reparative process. One of the contributing factor could be, I'll come to this one. We've actually labeled as a primary, secondary, and congenital. These are very uncommon lesions of obscure etiology. Can also have a systemic, association. Some of the systemic association in a primary keloid. Primary keloid means without any antecedent insult, whereas a secondary keloid following it could be in a trauma, surgery, or an infection, they're developing a keloid. So all this Lovis syndrome, Rubinstein-Thieback, and also one of the Ehlers-Danlos type have a tendency to develop keloid even without any trauma or insult to the cornea. Meaning, pathologically the genes which drive this process can also have a downstream pathway aberrant healing mechanism. Our intent is to report a clinicopathological correlation and to match them, the surgical outcome. Idea is, some of these cases tend to recur I need to identify what are those. This is a single surgeon institutional interventional case series. And here I'll be presenting about 22 children's. This 22 eyes of 18 patient. And we clinically classified, as I said, congenital, which is right from the birth, primary without any antecedent insult, secondary following a insult. And all primary keloids have an underlying syndrome, whereas acquired, we didn't find any syndromic association. And we carefully look at, they had a distinct histopathological pattern. So I'm matching here. This is a case of Rubinstein-Taiba congenital keloid. As a histology, we typed it as a type 2 healing pattern. Again, this particular case has a low-waist syndrome, which also subluxation, everything eventually child developed. Again, that histopath shows a type 2. This is, if you look at carefully, this is following a glaucoma surgery. This is chalky white. Unlike these are, these are a little more pinkish. It's completely white. There are no vascular element. We typed it as a type 1 keloid. Again, this is a mixed variant. No syndromic association. Similarly, here you can also see a fibrous pans. So why do we need to histologically categorize them to prognosticate? Those with a type 1 tend to have extremely poor prognosis. Those with a congenital tend to have a poorer prognosis. Histopath actually helps in precision-based, tailored surgical excision of this abnormal lesion and end up having an extremely good outcome. You can see 10-year follow-up following a lamellar surgery is almost as high as 86% without any recurrences. So I end my case here. Thank you for your kind attention.
Yeah, nice compilation of all the cases. So, can you clinically differentiate between a keloid and corneal opacities?
Yes, madam. Keloid, as I said, there are a raised, elevated, glistening lesion, and they extend beyond the actual site of insight. Unlike an hypertrophic scar, regular scar, it confined to the margins. So it goes well beyond the boundaries of insult. So the same with the dermatology literature.
Yeah.
And other thing is the histopath. Histopath is a key. What we found is an aberrant epithelium, hyalinized reactivated keratocytes. I believe these are abnormal keratocytes. For any insult, they have an exuberant response. So sometimes we don't know what drives that exuberant response. It could be genetic, some of the genetic association, because we've seen consistently. In certain cases, it's still obscure. But at least, if we can clinically categorize type 1, 2, 3, we know, we can, which are the cases. Congenital needs definitely full thickness, where even endothelium was absent. Whereas the primary, secondary, we can just do a Desmet's bearing, deep anterior lamellar keratoplasty. That will ensure, recurrence.
Have you seen, recurrence, that is what I was asking. Have you seen recurrences in any of your cases?
Yes, one case initially I did a superficial keratectomy with a mitomycin. Within a year, it became so aggressive, at least 3 times bigger than the original lesion.
Yeah.
Then I went for a DALC.
Okay, thank you. Thank you so much.
Thank you, madam.
One question, Muralidhar. Yeah, no, like the acquired variety, do they have an association with the skin keloids?
No, sir. All of them have received BCG. I did examine very carefully the BCG scar. I didn't see any keloid tendency, also in a family. And also, historically, if you look at malnutrition, tuberculosis seems to be one of the risk factor for keloid formation. And also, of course, racial, black race tend to have a higher keloid tendency than us.
But you have mentioned intrauterine injury.
Yes, sir. That is we do not know, sir. It's speculative. It could be, let's say rubella, but we could not find, when you run the titers.
Rubella we blame for congenital.
Yes, sir. Yes. Every time, you get everything positive.
So, do we have Nanthine Rajmohan? Dr. Alice Thomas? So, she will be presenting her paper on comparison of mesopic visual acuity, contrast sensitivity, and glare acuity between PDEC and OPK.
Good afternoon, everyone. So my topic is comparison of mesopic visual acuity, contrast sensitivity and glare acuity between PDEC and OPK. There are no financial interests. So as we all know, conventional penetrating keratoplasty has been the standard procedure for all corneal tissues in the past. It was associated with graft rejection, long recovery time, astigmatism. Then came the lamellar keratoplasty, which was associated with poor visual outcome resulting from irregular scattering of light at the recipient-donor interface. And then came the latest of all, the endothelial keratoplasty, which gave superior biomechanical integrity, better uncorrected visual acuity, and less induced astigmatism. So coming to PDEC, we all know it has better graft maneuverability, less manipulation, you can be taken from young donors, reduced risk of donor tissue loss, faster visual recovery. So here my objective is to compare mesopic visual acuity, contrast and glare acuity between PDEC and OPK, along with comparison of visual outcome and main indications for PDEC and OPK. So materials and methods, post-operative patients who underwent keratoplasty were selected depending on the inclusion and exclusion criteria. All patients doing PDEC and penetrating keratoplasty, all should be pseudophakic or clear lens status. Patients who have at least 6/18 best corrected vision post-operatively, and corneal graft clarity of at least 3 or 4 with grafts devoid of sutures were taken. And the exclusion criteria was any presence of any signs of graft rejections were excluded, and factors which can affect contrast sensitivity like glaucoma, retinal detachment, diabetic hypertensive retinopathy, ARMD, everything was excluded prior. Coming to methodology, informed consent was obtained, a comprehensive evaluation was done, uncorrected, best corrected visual acuity, slit lamp examination, corneal graft clarity, and presence of graft sutures. Here we utilized the corneal, the study was done using clinical trial suit machine. After checking photopic visual acuity, patient is dark adapted for 10 minutes. Best corrected lens is kept in trial frame and the other eye is blocked with an occluder. The luminance level was kept as 3 candelas per meter square and set for mesopic lighting conditions. The visual acuity is measured in mesopic luminance with glare on and off at 4 meters and with glare off at intermediate, that is 66 centimeter, and near at 40 centimeter. Mesopic contrast sensitivity is checked at 4 spatial frequencies, 1.5, 3, 6 and 12 cycles per degree. Coming to the results of the patients who underwent keratoplasty, maximum at the PDEC age group was found at 70 to 80 years and age group up to 40 years for OPK. The most common indication for surgery in 30 patients was pseudophakic bullous keratopathy, followed by fuchs, followed by endothelial decompensation and leukomatous corneal opacity. The study shows that the uncorrected visual acuity gained in PDEC was much better compared to OPK, which was statistically highly significant. The other features like best corrected visual acuity at distance and mesopic glare on at distance did not show much significance. There was no statistical significance in mesopic glare off at 4 meters and intermediate and mesopic near vision. The contrast sensitivity showed that there was significant difference at the 3 and 6 cycles per degree between PDEC and OPK, which was statistically highly significant, and there was no significant difference in contrast sensitivity at 12 cycles and 1.5 cycles per degree. Coming to few studies which have been done before, we have studied the uncorrected visual acuity between PK and PLK. There was better progressive improvement in vision from DLEC to DSEC to DSEC. And other studies also show that best corrected and uncorrected visual acuity was significantly better in DMEC compared to those underwent PKP. And corneal light scatter studies done by Sanjeevi Patel shows that there was significant effect of mesopic visual acuity in PK compared to healthy corneas. There was also a few other studies which studied DMEC, which shows significant low mesopic visual acuity after 6 months. So these are few studies which have been done before. Coming to my conclusion, uncorrected visual acuity was better in PDEC compared to OPK. Main indication was pseudophakic bullous keratopathy. And the mesopic visual acuity, the contrast sensitivity was better at 3 and 6 cycles per degree, and there was no significant difference in mesopic glare acuity. And this was the first study ever done to compare mesopic contrast sensitivity after PDEC. Thank you.
How did you select your cases for PK and PDEC?
This was taken after they have done the procedure, sir. We call them back after like 6 months. For PDEC, we call them after 6 months, and after PK, I call the patient after 1 year. Like after their serial follow-ups, I choose the patients.
No. My question is, who are the patients who received this penetrating keratoplasty and who received PDEC?
So those which have, after my study, I found out that the patients who had there is bullous keratopathy, fugues, there is some cases of traumatic corneal opacities, there was some scarred corneas, there was some ruptured keratoconus, not DALC, the advanced keratoconus cases, which has been taken up for the different procedures respectively, and we find out retrospectively find out which was done, and then we follow it up, and then we call them back after 1 year and 6 months.
Why you think that there is a difference between PK and PDEC, like contrast sensitivity? Why should there will be a difference?
Sir, in PDEC we are taking only the endothelium, predesmates and the desmates layer, sir. So there is, and in PK the entire cornea has been replaced, sir. So in uncorrected visual acuity, and there is presence of sutures in PK, and there is no sutures in PDEC. So coming to uncorrected visual acuity, there was significant difference found out in PDEC, sir.
That is there because of the cylindrical power
Yes.
you will have. But why you think for this contrast sensitivity and mesopic, why you think that there will be a difference?
In mesopic contrast sensitivity, actually, since lesser interfaces, less corneal tissues are interfered, the contrast part is affected less in PDEC, in endothelial keratoplasty, in PK. Compared to older studies also, they have found that in PK and endothelial keratoplasty, mesopic was better in PDEC, sir, in endothelial keratoplasty, sir.
Okay, thank you so much. So, do we have Dr. Lokeshwari? She will be presenting keratoconus family screening for studying prevalence in first degree relatives with corneal topography.
Good afternoon to everybody, and I would like to thank everybody for this opportunity to present in AIOC. I'm going to talk about keratoconus family screening for studying prevalence in first degree relatives with corneal topography. Keratoconus development is influenced by both genetic and environmental factors. Screening first degree relatives helps to identify the prevalence and subclinical cases in keratoconus. So identifying subclinical cases aids in preventing the progression of KCN and thereby preventing the environmental factors which cause the progression of the disease. The prevalence of keratoconus among siblings has been increasing in recent times, but clinicians as us, we don't have a clear data on this. Keratoconus patients and family members, they often ask us, will my children also develop keratoconus, or what is the probability? And siblings of KCN patients ask if laser vision correction is safe for them. So our research question is, in first degree family members of keratoconus patients, by doing corneal topographical screening, can we know the prevalence and even the subclinical cases of KCN and compare their topographic parameters with that of the normal patients? So this is a prospective case control study done over a period of 6 months in a tertiary eye care center in South India. So with these inclusion and exclusion criteria, we assessed the following topographical parameters like Kmax, the 3 and 5 millimeter zone irregularity, thinnest corneal thickness area, and the posterior float. So 29 families participated in this. So we could do topographical screening of 59 first degree family members. So we found that 46% of them did not have keratoconus. In the remaining 54%, 39% were subclinical cases and 15% were frank KCN cases. And 82 of the 82 controls, we did the topographical parameters, we compared it with the 82 controls we had. So we found that using the chi-square test that there was no significant difference in gender distribution between the cases and controls. When we compared the topographical parameters, we found that via the Mann-Whitney test, all the parameters were showed statistically significant difference between the relatives and controls. Several studies, not several, but a handful of studies had been done in other countries like China, France, Israel, and California. So in India, this is the first study of this kind. And in here, we have found in our study around 15%. And similar trend was seen in California and Iran. And a little higher incidence was seen in Israel and Lebanon. A slightly lower incidence in France. So the major limitation of our study was poor attendance among family members for disease screening. So Usually only one parent accompanies the patients, or siblings don't accompany, or because of cost reasons the entire family cannot undergo. So we recommend triple C's, that is, first counsel the family for regular screening, call them up regularly and remind them for a family screening, and the cost, try to reduce the cost when there is a family screening. We also recommend a multi-centered approach among different geographical locations and ethnic groups. So concluding, this is the first study of its kind conducted explicitly for family screening using topographical analysis. So we have some numbers to tell the clinicians now that it is around 54% the prevalence in family members. If the members asks will their children develop, then it may be, it is around 39% may be subclinical, and 15% of the family members may have frank keratoconus. There is no role for gender in this. And if the siblings ask about their safety for laser vision correction, we have a statistical difference of topographical parameters, but a clinical significance is not yet determined. We need to study that. So these are my references. Thank you.
In one line, what is your carry-home message for the audience?
Please encourage all your KCN patients to undergo a family screening. If possible, reduce because when if we take for a paying patient 2,000 to 2,500 per op scan, 10,000, asking them 10,000 per day is not practical. So try to reduce the cost and call them repeatedly for if they don't come. When we identify a patient, they're going to come to us for regular follow-up. So even if that day they are not able to come, when C3R is planned or anything like that, please come repeatedly.
So from my clinical experience also, I can add that we all may agree to it, that cases of keratoconus are on rise. I mean, we have also become more conscious perhaps in diagnosing, and public has also started getting awareness of this particular problem. In our days, keratoconus, a very short note will come in theory paper and disappear. But now, it has really become a challenge. Keratoconus requires a day-long discussion. But I think it's a good study to begin with and to take care. Thank you, ma'am.
Thank you. Thank you.
So, do we have Dr. Sonali Prasad? So, she will be presenting her paper on microbial keratitis and antibiotic sensitivity patterns, a retrospective analysis in Central India.
A very good afternoon. First of all, thank you, AIS, for giving me this opportunity. So I'm going to talk about the microbial keratitis and antibiotic sensitivity pattern, a retrospective analysis in Central India. So microbial keratitis is a suppurative inflammation of the cornea, and it is a leading cause of corneal blindness. Roughly of 1.5 to 2 million cases are globally affected because of its rapid progression. It is mostly caused by bacteria, virus, fungi, and there is a regional variation in the predominance of different organisms. This can be due to the influence of risk factors or climate or geographical variations. So it is important to analyze the recent pattern of etiological agent causing infective keratitis and their sensitivity in a particular geographical area. This will help us in making an evidence-based decision in choosing the appropriate empirical therapy. So aim was to report the infective keratitis, microbial profile and antibiotic sensitive pattern at tertiary part of Central India. It was a retrospective study conducted for 2 years, and a proper institutional review board was taken. So we define infective keratitis as patients having corneal ulcers with loss of a corneal epithelium and underlying stromal infiltration and suppuration with signs of inflammation with or without hypopyon. So all diagnosed cases of severe keratitis were taken from the OPD basis. We excluded keratitis of sterile, neurotropic or autoimmune nature, and patients who could not come for follow-ups or concurrent endophthalmitis or nil microbiological interventions. So after a patient came to us, we filled a standard form for documenting his ocular history of trauma, contact lens wear, corticosteroid use, systemic illness, corneal finding, including the corneal diagram with socioeconomic details and predisposing factors. We did a corneal scraping and culture for all the patients, and the sensitivity was checked with the help of Vitek 2 machine, which is an automated photometric system, and it gives results in just 6 to 12 hours. No financial disclosures. So results, out of 455 patients, 143 were male, and the culture positivity was seen in around 233, that is 51% of the patients showed culture positive. Pure bacterial was seen in around 35 patients, and 62 predominant of our growth was purely fungus. Among the bacterial isolates, the gram negative was seen in 52% and gram positive was seen in 47%. Pseudomonas was the most common bacterial gram-negative bacteria, followed by Klebsiella. Among the gram-positive, we have Staphylococcus, followed by Bacillus and Streptococcus. Fungus was the overall most common organism, with unidentified hyaline fungus being the most common organism. Coming to the sensitivity pattern, the Pseudomonas was 89% sensitive to colistin, with 65 to 75 resistance to other antibiotics. Staphylococcus was 100% susceptible towards Vanco, imipenem, and 65 to 70% resistant to other common antibiotics. Streptococcus was mostly 100% sensitive to a lot of antibiotics, with 66.67 resistance to levoflox and 33% resistance to moxifloxacin. So coming to discussion, clinical outcomes in microbial pattern and epidemiological pattern may be different in different parts of the country, also between the different countries, between the geographical areas. So it is very important to analyze a recent pattern of etiological agent in your area and formulating an evidence-based decision on choosing the antibiotics. So there has been multiple studies from South India documenting their most common organism and their sensitivity pattern, studies from Eastern India, studies from North India. This was a study multicentric where our institute had also incorporated some data, and Staphylococcus was again most common. So limitation of our study, it is a single center study, but still patients mostly were poor compliant and had been treated earlier by non-ophthalms and low socioeconomic patients. The Vitic-2 machine is not an exclusive ophthalmic use, it is for a general medicine use. And so conclusion, although it was a single center study, the data that we had definitely provide a better understanding of the current pattern of infective keratitis in the rural setups, formulating a structured protocol. So unnecessary, it will also prevent the unnecessary use of antibiotics and further resistance. Thank you.
How different is the this thing observation from South Indian study and that is Aravinda study and
sir, mostly they also sir, we had Staphylococcus and they mostly have Streptococcus as the most common gram-positive bacteria. Also in fungus they had Fusarium and Aspergillus most common, which was a little different.
Talking about Aravind study?
Similarly, all the South Indian papers were quite similar. We, irrespective of other studies, Streptococcus was more common in our setup, more than Staphylococcus. That was a difference, sir. And the sensitivity pattern also, the Staphylococcus that we had was more sensitive to other organisms, other antibiotics, sir.
How many cases you have done culture and how much?
Sir, 455, total 455, out of which 235 were positive, almost 51% were culture positive and 49% were culture negative. So out of the positives, sir, 60% were fungus.
And most common was like?
Overall, most common was fungus, sir.
What empirical treatment you want to start with these cases?
So normally what we do it in our practice, we either first of all, depending on the microbiological, we wait for the scraping. Not culture is not done in every patient that we have in the OPD because the workload is too much. So depending upon the scraping, we give moxifloxacin now only. For the bacterial and for the fungus, we start the patient on netamycin, sir.
I think this is a very complex, like microbial keratitis
Yes.
is not like something
Yes.
which anybody can define.
Yes.
So we'll, yeah.
So unlike staph and strep, they are critical common cells.
Yes, sir.
Within Pseudomonas multiresistance coming from
Yes, sir. We have actually faced that issue a lot in some of the patients. Sir, actually we had also published this paper, so it has a table with all the organisms and particular sensitivity, some of the organisms that were resistant to most of the antibiotics. So we had to make formulated, for example, gram-negative, we had to start colistin or other antibiotics that the patient was coming sensitive to. A lot of patients were resistant to most of the antibiotics. So, but those cases were quite less that we faced. Yes. Most, sir, in our population, it was agricultural workers, male agricultural workers. Yes, sir. 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 Yes, sir.
और नहीं है ये सभी लोग नहीं है क्या?
Yes, sir. Yes, sir.
नहीं है ना?
Yes, sir. Yes, sir. Yes, sir. Yes, sir. That has mostly happened patient who had multiple layers of treatment previously. A cocktail treatment was started in those patients previously. So those patients when landed up to us were resistant to most of the antibiotics, sir. Thank you, sir.
Thank you. Do we have Dr. Mugundan and Dr. Lionel Raj and Dr. Raj Mohan?
I think we'll conclude the session with this because, and we can have a photograph